Now we are moving on to our last sections, and especially the joint disorders, especially when it's a periarticular trauma. For example, the trauma which is affecting the knee joint, it could be distal femur fractures, supracondylar femur fractures, or it could be sciatica fracture, which mainly in the proximal tibia. So usually in periarticular trauma, the joint may be affected as well. This could be in form of later on may present with joint instability and joint stiffness. There could be post-traumatic osteoarthritis with the joint, or there could be associated with complex regional pain syndrome, which may be present post-trauma as well. And we'll be briefly discussing in this section all this. Now coming to the joint instability. Joint instability causes could be many, but usually may be associated with the trauma as well. This could be in the form of ligamentous laxity. This could be in the form of muscle weakness or bone loss. If conservative treatment for the joint was done, this may lead to joint stiffness, and ligamentous laxity may not be seen initially. But once the bone is united and the patient is in the rehabilitation phase, this ligamentous laxity may present him or her from properly rehabilitating. And this can be disaster at times because there will be frequent trips and falls, especially following the ligamentous laxity of the knee joint. So this can lead to recurrent dislocation. We need to prevent that. Commonest sites are usually shoulder and patella, that is around the knee and shoulder. Other problem could be associated with joint stiffness. Now, joint stiffness could be either due to the problem which was at this level of happened during the part of the trauma. This could be massive soft tissue damage, and there could be massive inflammation, eventually leading to fibrosis, and could lead to joint stiffness. Or this could be due to the conservative treatment. If a cast was applied and patient joint was immobilized for, let's say, 4 to 6 weeks, and once the cast was removed, the patient did not rehabilitate properly, and this has resulted in the joint stiffness over 4 to 6 months period of time. So this could be most commonly it's in form of knee, because patients usually don't walk after POP is removed. It could be in form of elbow or shoulder, where there will be massive decreased range of motion. This may be due to actually the stiffness may be due to hemarthrosis formation, which happened actually at the time of injury. Other could be due to the synovial adhesions or fibrosis which has occurred and may be leading to joint stiffness. And lastly, the cause of the joint stiffness is actually complex regional pain syndrome or reflex sympathetic dystrophy, in which there is actually massive pain out of proportion, and the patient thinks that this pain is actually due to the trauma, the bone fracture which has occurred, and therefore does not move his joint, and eventually leads to joint stiffness. Now coming to the treatment. First and foremost is prevention. You have to counsel the patients that once the POP is removed, you will be moving your limbs, and if you're not going to move your limb, probably you're going to result in joint stiffness, which is going to be a bigger problem than the fracture itself. The other options include exercise and physiotherapy. You have to tell them the exercise regimen, and the aggressive physiotherapy has to be started so that rehabilitation can be done easily. That is in form of holding the joint in position of safe immobilization initially if the bone has not completely united. Other option is if the fibrosis has occurred in the knee, the arthroscopic and guided releases can be done as well, especially in the case of shoulder and the knee. Other option is adherent or contracted tissues can be released by surgically so that movement can be restored back at the joint. But that is once the joint stiffness is so much that it's actually affecting the daily activities of daily living. But usually with prevention and exercise and physiotherapy, most of the joint contractures can be treated. Now coming to the post-traumatic osteoarthritis. This is also very rare but can occur with especially in a periarticular trauma. Fractures involving a joint may severely damage the cartilage and give rise to post-traumatic osteoarthritis within the period of months, which may not be present initially, but over 6 months to 1 year time, you usually see arthritic changes or degenerative changes in the joint, which was previously very much normal. For example, it's commonly seen in case of a knee, if one side of the knee is severely affected, the other knee is absolutely normal. Usually it happens when that knee had a trauma, let's say 6 months or 8 months or 9 months back, and now it has developed post-traumatic arthritis. This actually results in due to the irregularity of joint surface at the time of injury. There's localized stress, inflammation, and fibrosis over there. Eventually, there may be a metaphyseal fractures as well, which may eventually malunion metaphyseal fracture. There's an articular step, which is actually resulting in post-traumatic osteoarthritis. Now coming to the complex regional pain syndrome, it's a very rare disease. but it may be actually the problem which is disseminating in such a form that it may be leading to multiple other problems such as joint stiffness, decreased movement, and poor outcome, which is suspected especially of the rehab protocol. This could be called as complex regional pain syndrome, or previously it was called as regional sympathetic dystrophy. What happens is basically there is sympathetic dystrophy in which the patient is actually feeling a lot of pain out of proportion, especially associated with spinal cord injury or head injury. And these patients have this kind of a problem that, for example, if you see this is this kind of a skinny appearance, especially there's a red, warm and swollen foot, especially associated with the pain, is a classical symptom of a complex regional pain syndrome associated with ankle trauma. There are two types. Type 1 is actually reflex sympathetic dystrophy, develops after injury or usually a noxious event. Type 2 is actually causalgia. Causalgia is due to the involvement of nerves which may be associated with nerve injury which happened at the time of a trauma or at the time of the fractures. This may lead to eventually this kind of a syndrome. Usually X-ray are continuously shown patchy rarefaction of the bone, and but the problem is actually not the bone, it's not around the joint as well. X-ray, the problem is with the sympathetic discharges which is actually happening through the nerves of the sympathetic ganglia. The treatment is actually elevation and active exercises. Yes, you need to give them neuromodulator at times, but most commonly elevation active exercises helps them. Anti-inflammatory drugs can be given as well because that reduces the swelling and discharge of the sympathetic ganglia. Adequate analgesia, because sometimes these patients may be having severe pain out of proportion as well. And desensitization method, it could be in form of nerve blocks, neuromodulators, or even the nerve injections as well. Then there may be a dedicated physiotherapy because a specific type of physiotherapy is required as well. That is in form of that is called as hot and cold physiotherapy. That if, for example, there is a lot of problem with the hand wrist joint, then you ask them to dip your hand in the hot water first for a few minutes, then do some physiotherapy, then dip the same hand in the cold water for some time, and then do the exercises as well. So this is a dedicated specific type of physiotherapy which is required, so that because nerves are actually hyperactivated and hyperstimulated, so they need to be toned down so that there is not excessive sympathetic discharge which can occur. Obviously surgery is an option, but usually it's only left for very advanced cases in which sympathectomy is done, or usually a sympathetic nerves are actually cut so that the discharge which is actually coming down is toned down or decreased. In this section, we briefly discussed one of the very late complications of the fractures, which could be in form of periarticular fractures especially. This could be either formation of hematoma, which eventually leads to synovial fibrosis or ankylosis of the joint as well, or this could be in form of a joint stiffness as well. Joint stiffness is one of the very common problem, especially associated with the conservative treatment or POP casting. And once the POP is not removed, the patient may be feeling the pain due to multiple other reasons such as complex regional pain syndrome or other as well. And that result does not move his or her limb, eventually leading to joint stiffness. And then joint stiffness can be either prevented, or then if we have to treat it, this may require treatment in arthroscopic treatment or even surgical treatment of releasing of the contractures. We briefly discussed the complex regional pain syndrome, although it's an entity really not properly understood, but it's kind of a sympathetic problem which actually is repetitive sympathetic discharges which are due to associated with the trauma, and this can lead to a severe form of pain. Patient may not be able to move his or her limb, and eventually leading to stiffness. So the treatment is actually directed at the sympathetic discharge as well as the pain. It could be in form of analgesics, it could be in form of nerve blocks, it could be in form of neuromodulators, it could be in form of physiotherapy as well. And yes, there are surgical treatments which are only reserved for very advanced cases. Thank you very much. Keep watching sqadia.com.